Good evening, everyone. Thank you for having me. And it's a pleasure to have these meetings again in person. My name is Paul Hanna, and I'll be sharing a case with you today regarding our management of a type 1A endo leak following the treatment of a patient that had a ruptured type B aortic dissection. I have no disclosures. The patient is a 58-year-old female who presented to our emergency department with acute onset back pain and chest pain that's been going on for about 2 days now. She complains of associated nausea, vomiting, and some lightheadedness, and she describes the pain as persistent and worse with movement. Otherwise, a nice shortness of breath, abdominal pain, or extremity pain. And of important note, she has been non-compliant with her blood pressure medications for the past month, as patients do. Other past medical history is CKD stage 2, not on renal replacement therapy, and she, of course, is a smoker with a half pack per day times 40 years. On physical examination, heart rate is 128 and blood pressure is 214 over 120. On the left side, she does have decreased breath sounds. Otherwise, her physical exam is overall unremarkable. We can see her chest x-ray here on the left lower side. There's a little bit of weirdness there. We can see it a lot clearer when we look at the CAT scan here. And so let's take a look at this together. We see clearly this effusion on the left side, and let's follow the branch, the arch vessels. The arch comes down, and right about here, we can see the clear dissection with the large effusion right behind it, with the blood pressure parameters that are abnormal. And so this was consistent with a ruptured state. And so this continues. You can see multiple fenestrations here. And I'm going to fast forward just a little bit down here, and right around the renal vessels is where everything turns back into true lumen. And so according to the STS SVS classification system, this is categorized as a type B3, 3 for the location of the entry tear and 7 for the location of the exit site. And so this starts in 3 just distal to the left subclavian artery and extends to just above the renal vessels. You can see here on multiplanar images the multiple fenestration flaps within this dissection. And so looking at a 3D reconstruction of what this aortic arch looks like and where this rupture is, we can see that from the location of the rupture and of the entry tear to the location of the left subclavian artery, we have 31 millimeters. And so at this time, the decision was also being made of, well, do we cover the left subclavian artery when we go ahead and treat this with our stent graft? And so if we were to cover the left subclavian artery, that would gain us an additional 8.9 millimeters. And so based on those measurements of 31 millimeters, we felt that that was adequate at the time. And so we proceeded to take this patient to the operating room, placed a Cook Zenith endograft, which we can see here most proximally has these bare metal hooks. And the rest of the fabric starts right after it. And we did not cover the left subclavian artery in this location. And then we extended it from there with a petticoat, which is the provisional extension to induce complete attachment, which is a bare metal stent that extends down over the entire visceral segment of the aorta in order to promote growth of the false lumen to be thrombosed. From there on, the patient required postoperative thoracentesis as we expected. She had a large hemothorax in that area. She overall did well, was discharged from the hospital on postoperative day number 4. 2 weeks later, this was her postoperative CT scan, and everything looks pretty good here. We can see that bare metal stent, which looks like it's covering that left subclavian. That's just bare metal. There's no fabric there. And then we look at her CT scan, and it looks quite pristine. The false lumen looks like it's becoming completely thrombosed. The true lumen is expanding. We have no extravasation of contrast. And so from there on, everything looked like it was going to go just fine. But of course, the reason that we're presenting this, 6 months later, she comes back with the complication. She returns to our ED with 2 days of pain, and the pain was not positional, not changing with aspirations. She overall says that this felt just like it did the first time that she came in with the rupture 6 months prior. Physical exam, otherwise unremarkable. We got a CT scan, and this is where it looks a little bit more interesting. I'm going to play the scan here, and let's follow the arch vessels down. And so we can immediately see here this filling of the, let me play that one more time. There's filling right here into this aneurysm sac. We can see that everything looks just a bit bigger than it did on the first CT that we looked at prior to this. And so when we compare these two CT scan images side by side, let me see if I can. When we compare these two, this is 2 weeks post-op on the left. This is the current one at 6 months now. The red arrow is looking at those bare metal hooks on that Zenith alpha graph. The blue arrow is looking at the left subclavian artery on both of these images. When we look at the image on the left, the bare metal hook is right under that left subclavian artery. We look at the image on the right. that left subclavian artery is quite a bit of a distance away from those bare metal hooks. And so it looks to us, based on this immediate picture, that this stent made its way down and migrated distally. When we look a little bit closer and we get the diameters for this vessel all the way through at 2 weeks post-op, we had a diameter of approximately 25 millimeters, which then 6 months later grew to 34 millimeters, a little bit more distal, about 42 to 43. And so not only did it migrate, what happened here is that there was aneurysmal degeneration of this aorta proximal to where the stent graft was placed. And so the aorta degenerated, and the remainder of the graft made its way a little bit forward. And so then our decision-making had to become in as to what do we do now? Covering that left subclavian artery is not going to give us the 2 centimeters of coverage that we need. And then if we just leave that there, we're going to end up having this bird beaking appearance, and it's not going to sit comfortably. And so we made a plan of care between ourselves as well as our cardiothoracic surgery colleagues. And we made it a staged repair, starting with the left carotid subclavian bypass. And then we took the patient for a open aortic arch to innominate bypass. And so once we had that bypass completed, you can see this on the right side of the screen on the 3D reconstruction. Right off of the arch is where we get the innominate and the carotid artery. And so then we took the patient back to the operating room for the endovascular portion of the procedure. And what you can see there on this red arrow is a pacing wire that we placed around our anastomosis in the operating room when we took the patient for the bypass. And that's to help us figure out where exactly our exact landing zone is going to be. What we're looking at on the blue line is our transvenous pacing wire. Generally, we don't always use these for TVARs, but in a situation in which we wanted to truly be very precise, we did pace the patient to 160 beats per minute in order to have a better picture and be able to have adequate landing zone. And so this was our first angiographic image when we took the patient back into the hybrid room. You can see here filling of that false lumen as we expect in the entire aneurysm sac. We went ahead from there and we extended this with another zenith alpha endograft, and we brought this all the way down to zone 0, in which we were able to cover basically the entire arch. And now we have, between the aorta innominate bypass and the carotid subclavian bypass on the left, the vessels are all covered up. We then completed with placing an AM Platzer plug in the left subclavian artery. And then this is her CT scan 8 weeks post-op, as well as 1 year post-op. It has remained identical to this, in which the true lumen has completely expanded. There's no further leaking into the aneurysm sac, and the false lumen has regressed, and we can see the positive remodeling here. And so I share this case because in vascular surgery and really all of our specialties, we're all very technically talented. We can do whatever we want from a technical standpoint, but this is one of those cases where decision-making really became the pivotal portion of how this patient is going to do, whether it came down to the decision of covering the left subclavian artery or how we're going to manage this patient overall in a rupture situation. Do we just get them off the table and live to fight another day, or do we try to treat it all at that moment in time? And so dissections in general of the aorta are a very complicated area in which all the management is still very controversial. And we see data that was published from the STABLE trial, the STABLE 1 trial, as well as the STABLE 2 trial, that had shown that treating patients within the acute phase as well as during the subacute phase still showed favorable clinical and anatomic outcomes, which is contrary to some of the beliefs that we believed prior to that. And even now, we still don't often follow those restrictions, as there's lots of data showing that treating patients during this acute or subacute period has a very high rate of having retro type A dissections, as well as spinal cord ischemia. And so as this information continues to change, we then have the INSTED trial and the INSTED Excel trial, and the work done by Dr. Joseph Lombardi and Dr. Christoph Neinabar, which show us that treating patients with TVAR plus optimal medical therapy has decreased the absolute risk of having a complication with these patients significantly, from 46% all the way down to 27%, with a 19% absolute risk reduction. And so the optimal management for these patients, while this is the data that we have, and while these are the main studies that we have telling us what we should do, I believe that over the next decade of our career, this information is going to be changing significantly. Whether or not our techniques are going to be what changes, our decision-making is certainly going to. And with that, thank you for the honor of the podium, and I'm happy to take any questions.
Thank you very much. Excellent case. Any question, judges?
No, the first option you had, that to cover the left subclavian artery and bypass, that should have, if you had done that, probably could have avoided the second.
Maybe.
You thought about
I,
it, you
I
had the
don't,
plan.
I don't believe that it would have in hindsight, and that's only with the gift of hindsight that I can say that. If I were to go back altogether,
Right.
empirically, the left subclavian artery should be covered, and if the patient has symptoms afterwards, we'll deal with that. We'll do the left carotid subclavian bypass, and then figure out what we need to figure out from there. But looking at this CAT scan, I don't believe that that would have made a difference. And the reason I say that is looking at that aortic arch right where that entry tear is, and even proximal to that, it's full of thrombus. And so even though the dissection is not within that region, there is thrombus within that aorta. And I believe that if we truly wanted to avoid this, the patient would have had to undergo that zone 0 bypass from the beginning of it, which just would have never happened given the rupture situation that she was in.
Very nice case. Quick question: how did you size your first stent graft? Right, because it's not an easy decision. You want to oversize it enough that you push your true lumen and expand it and seal off the rupture, but you don't want to oversize it so you get aneurysmal degeneration or you get a retrograde dissection. So how do you size your stent graft?
So the way that we size our stent graft, we do a couple of things. If I could go back to the slides for just a second, I could show the CT to kind of answer that question. No problem. So we do a 10% size increase in the way that we measure it, one with IVUS, and two, based on the CAT scan, looking at an area that's approximately 3 centimeters of length of the aorta that is uniform, and within that area, measuring wall to wall of the longest length of that crescent portion of the aorta, and then upsizing from there by 10%, and then confirming that with IVUS.
Okay,
Thank you.
thank you so much.
Thank you.
Thank you
Yeah.
very much. Excellent.